Okay, so first I must thank my clinical society as well as the Ceylon College of Physicians for giving me this opportunity to talk to you. And so I happen to be the last one and the one between a very nice lunch and a hungry bunch of people. So not a good place to be. So I try to make this as even simpler as possible. So that nagging cough. So all of us have had a cough at some point of time in our lives, and the symptom of cough is a nagging one. It's not a severe symptom so as to disturb our day-to-day lives or to get admitted or something, but still it keeps on troubling us when we get that. But if the cough is a little protracted and it's nagging, the impact will be a little more. So in a chronic cough, how do the patients feel? What are the impacts a chronic cough can cause to the patients? So it affects not only the patient, but also the individuals around the patient. And most of the time, so why do they seek help? So one thing is they are concerned that the cough that has been going on for so long with no response to treatment, whether this is something serious underlying. Also, the cough makes them exhausted, disrupts their sleep. Sometimes they can get what we call a cough syncope. They get a severe bout of cough and then they lose consciousness, like our neurologist told a little while ago. Then, of course, social embarrassment, particularly in females. This can precipitate urinary incontinence and it's annoyance to everybody around. So if somebody is coughing in front in the audience, it will be annoying to all of us. Right. So the best way to assess the severity would be to ask the patient to tell us how severe is your cough. If you score your cough from 1 to 10, what's the number you will give? So this will help you to understand how impactful the cough is to the patient, as well as it will it will help you to evaluate the treatment response once you start the treatment. Right. So what do we call a chronic cough? These are arbitrary values, but normally we call it, if a cough is lasting for more than 4 weeks in adults, we call it a chronic cough. However, this is, like I said, this is just a numerical value, but does it really tell us whether it's a chronic cough? Because sometimes if the patient is having a cough, say for a week of the month and the next month he gets it again and it goes on for a year, is it a chronic cough? Is it something different? And we need to understand that the cough, a chronic cough, is a disease in itself, and there are different phenotypes. That is, there are different reasons and different manifestations, although the symptom is a long-lasting cough. So, like I said, if you fail to identify that this is a single disease entity that's running along in this patient, we will wrongly diagnose these patients as whether he's having a poorly controlled asthma, recurrent chest infections, or exacerbations of COPD. But what exactly the patient is having is a chronic protracted cough, which we need to evaluate. So I'm sure we have met these type of patients. So do you recognize this one? A lady, 53-year-old, middle-aged, little older, a teacher, previously well, no atopic features, and she's coming to us seeking help for the cough that she's been having. So it has started about 6 months ago after a difficult common cold, which has not gone away according to her, but she does not have any other symptoms. There's no dyspnea, there's no wheezing, little or no phlegm, no dyspeptic symptoms, so no GORD features. The patient is not complaining, and lately it has got little worse with the even with the slightest irritating stimuli, maybe a bit of dust, maybe a chalk dust or something like that. And a typical complaint of these type of patients are they're complaining, they're telling you උගුර හැම වෙලේම උගුර පාදන්න. There's උගුර පැටලෙනවා හැම වෙලේම. So always they will tell you there's a nagging tickle at the back of the throat. It's a typical symptom. Right, and yes, it's impactful, the cough itself, and of course she's a school teacher, so students, when she's teaching, as well as the colleagues in the staff room, are a little bit irritated because of the cough that she's been having. Okay, so what's going on? What do you think that is going on with this lady who is apparently well before, no other symptoms, just a cough going on for the past 6 months? There are a few postulates, or there are a few reasons that we all know that can cause this chronic coughs. Is it asthma? Is it acid reflux? Whether it's a post-nasal drip or something else? Because all these the phenomena can cause a chronic cough. But is it the only causal? Are they the only causal factors, or if they are the causal factors, how much are they contributing to this chronic cough, or is there something else also going on? So the pathophysiology, now this has become a newfound pathophysiological explanations for this chronic cough. So it's not something like asthma, or it's not something due to inflammation mainly. It's predominantly, they consider it as now due to neural mediated afferent, that is afferent vagal hypersensitivity triggering this cough. So the patients have got neural hypersensitivity of the cough reflex. The triggers could be several. It could be either thermal, chemical, or mechanical stimulations. So it's mainly, the thought process now is that it's mainly a neuro-mediated pathogenesis. Right. So we have to, because this is a neural mediated, there are several possibilities, and so we have to think about this as a overarching or an umbrella term which encompasses a lot of other phenotypes. This helps to explain our patients what's going on, as well as this lets us use many other treatment modalities, and also to also the patients and the carers will understand what's going on if we give this as a diagnosis of a disease called chronic cough. Right. So in an adult, how do we go about assessing the chronic cough? So there are few things that we need to consider. Of course, a good history and a physical examination is mandatory, because chronic cough, like I told, the patients who come with are worried that this could be a significant underlying disease, so we definitely need to exclude those. But in general, you need to evaluate the cough with simple questions like the cough duration, how badly it affects you, and if there's a family history, and then like I told you in the beginning, you assess the cough, give it a score, ask them whether he can score their cough from 1 to 10, whether it's a 6 or an 8 or a 3, and then you need to assess about this is reflux. Objectively, to assess acid reflux, you have different questionnaires, you can use that. Then of course you have to assess different associated symptoms in the throat, chest, or in the GI system. Also, any risk factors need to be evaluated, like medication history and smoking. Physical examination need to be thorough, including the ear and nose. The evaluation routinely, what do we need to evaluate? So any patient coming to you with chronic cough, these tests, the investigations are mandatory. So you have to do the chest X-rays mandatory. So the patient coming to you with a chronic cough, you have to, the patient has to have an X-ray. Also a lung functions, because these days we do not diagnose obstructive airway diseases without a lung function test. In the these are not in the guidelines, the sputum, but in our Sri Lankan context, anybody who's having a cough more than 2 weeks duration is a TB suspect, so you have to screen for that. Then you need to do a full blood count. What we are looking for is, we normally tend to overlook in a full blood count the eosinophil count. So specifically, do a full blood count looking for eosinophils. This is a bit not available to us, but the exhaled nitric oxide levels, there are tiny machines that you can use to measure the level of nitric oxide that is being exhaled. So it's a surrogate marker of, again, eosinophilic inflammation in your airways. So it's similar to what you do with the full blood count and looking for eosinophils there. Right, so you need to do the assessment. So why are we doing this? Again, to look for sinister pathologies, as well as trying to identify if there are any treatable traits or different phenotypes of cough, that which we call. Right, so there are different phenotypes of chronic cough, which we, if we try and identify, will help us in managing this patient. So what are the phenotypes? You have what is called asthmatic cough. It could be asthma, or it could be lying somewhere in the asthma spectrum. One end is the asthmatic cough, the other one is eosinophilic bronchitis. And then reflux cough. We'll come back to this in little detail. That is the cough due to neural stimulation by having gastroesophageal or other reflux. Then you have another one, our ENT colleagues are a little fond of this, which we call upper airway cough syndromes or postnasal drip. So that is some irritation in the upper airways, like in the like in rhinitis, sinusitis. So people having those, if they are having a chronic cough, we call it an upper airway cough syndrome. And then iatrogenic is there are certain medications that can cause a protracted cough. The important one, again, cough associated with other diseases, could be malignancy, pleural disease, interstitial lung disease, and things like that. So it's another phenotype. But the other one, the one that we are talking today, will be the chronic refractory cough, or the what we call an idiopathic cough. Right, a little bit about these the phenotypes. So asthmatic cough. So this is a spectrum of a cough. So asthmatic cough, of course, if the patient is having asthma symptoms, then it's asthma. So that's one end. Other one is eosinophilic bronchitis, because the patient is having a eosinophilic inflammation in the airways, but it does not have any other features to suggest asthma. In between, you have the cough variant asthma, right? So to detect these, the reason why we do the eosinophil assessment is to see whether this is a this falls into this phenotype. Then what about the reflux cough? So reflux cough is, again, if you get acid reflux into your pharynx, you can get mechanical, chemical stimulation and get the vagal afferents going and cause a chronic cough. But evidence is that it's not entirely true. So if you have acid reflux, yes, if you treat, sometimes the patient might get better, but not all the time, because there's a concept called non-acid reflux as well. So if you treat with, even the patient is not having acid reflux, if the patient is having either gaseous or liquid reflux, either from the stomach or the esophagus, still the patient can have a cough. Yeah, then the postnasal drip or upper airway cough syndrome. There's a debate whether this is a real true phenomenon, but things associated with rhinitis or sinusitis causing local irritation may cause a cough. But the things against is that sometimes you treat with local preparations or antihistamines, the patients do not respond. So then this may not be a true case, but the treatment may have worked in some cases, triggering this concept that this could be the postnasal drip, is that the countries that are fond of this terminology is the America. So they are the doctors are using first generation antihistamine. So first generation ones, apart from sorting out the rhinitis and the components, what it does is it crosses the blood-brain barrier and makes you cough less. So it's really a neural mediated cure that is happening. Okay, the iatrogenic cough, of course, we all know this is very familiar. Different drugs, medications that patients have, like ACE inhibitors and other things that affect the GI motility, can cause the iatrogenic cough. Then the cough associated with other diseases, yeah, you can get heart failure, interstitial disease, pleural disease, and these things can cause. So if your patient does not fall into any of these phenotypes, it's likely that the patient is having chronic epilepsy. Right, coming back to our patient. So we've done a good physical examination, nothing was found, and the blood samples, we've done all those things, and they come all negative. So what are we going to do now? So what if the chest X-ray is normal? So the bloods are normal, lung functions are fine, has got a 6 months of cough, and what are we going to do next? What about the CT scan? So do we have to do a CT scan on a patient who has been properly evaluated in the manner that I told? So what are the pros and cons, and what are the evidence? And what about a bronchoscopy? So bronchoscopy, again, do we have to do a bronchoscopy to see whether this patient is having anything nasty inside his airways? So the evidence is that routinely we don't have to do a CT scan in these types of patients. Why do they say it? If there is something that is causing the chronic cough, it will be visible in your chest X-ray. So if it is not visible in the chest X-ray, it will not be the cause, it will not be the etiology of your chronic cough. But if you do a CT scan, you might find different things in the scan, but they can be called incidental. You may find a nodule, you may find a bronchitis, but that may not be that is not the reason for the chronic cough. So if you treat what you find in a CT scan, still the cough may not settle. So that's the theory behind, the evidence behind not needing to do a CT scan if you have properly evaluated the patient. And also CT obviously has a radiation exposure. What about the bronchoscopy? It's again the same. So for a bronchoscopy, it's again what you call a high risk investigation, potentially life threatening. 5% of the time you can get life threatening complications. So do we need to subject this patient to such an investigation? Not really. But of course, uh, you may have, say, like for a we don't have easy access to CT scans, but we do have fairly easy access to bronchoscopy. So if you think maybe you can do it, but if you should be able to accept the risk and explain. So nobody can find a fault if you do not do these investigations in a chronic cough patients, provided that you have done the proper evaluation. Okay. So we have tried to find a etiology, tried to find a detectable cause, treatable trait, or a phenotype that we can treat. So nothing was found. So it's a truly a nagging cough that nags the patient until the patient comes to you, and patient nags. So you are nagged by the patient. Okay. So how are we going to go about treating this patient? So initial management, you have to stop risk factors, obviously. So whether he's a smoker, he has any exposure to industrial dust, fumes, oil, agrochemicals, occupational, organic, inorganic matters, you try to stop those exposures. And then, depending on what you found, even if you don't have found, if you have not found the evidence, these are not very strong evidence-based medicine, but we do not have any other drugs to treat at the moment. So these are ones which low quality evidence, but we have to use. So what are the things? So we can use inhaled or oral corticosteroids, but normally we have to give these a little longer. Therefore, inhaled corticosteroids are preferred. And then you can also try with Montelukast, leukotriene receptor. And we normally tend to give PPIs as well to these patients, thinking that it is due to acid reflux. But if there's no evidence of acid reflux, this will not help. So initiate them only if you have evidence to say that the patient is having acid reflux as a cause for the possible chronic cough. Right. So coming moving forward further. So I have underlined the the trial, the word trials in red, and I've underlined it. Why? Because not these are all on trial basis. We are trying to give different medications, hoping that the patient will respond. So these are all therapeutic trials. They are not treatment. So you have to, when you treat the patient, you have to tell them that we are trying these things. These are not the real medication. We'll try this to see if it helps. Yeah. So you give inhaled corticosteroids, you have to give a little higher dose than the normal smaller doses, because otherwise it will not, the evidence is for that. And then if you think, or if you are a believer of upper Airway syndrome or the post-nasal drip, yes, you can give antihistamines or steroid nasal sprays. The duration of these trials should be 2 to 4 weeks. You have to, if they're not responding, tell the patient, okay, yeah, I'm doing this as a trial. Look, it's not responding, so why don't we stop? Okay. But if the patient is responding, continue it for a little longer, 3 months, and then try to withdraw and stop. Okay, so these are the medication that we have been, we are commonly using and we have in our easy access. But like I told you, not good evidence that these are really working, because the cough is the pathophysiology of this chronic cough is a neuromodulation. So what we need to treat the patients with are the drugs that can block these vagal arteries, right? So good drug will be low dose opiates. Unfortunately, we do not have access. So if you give low dose oral morphine, they respond very well within a week or so. But so if you have, that's a good drug, and it has actually moderate strength evidence. So if you don't have this, or if the patient is not responding to opiates, you can give gabapentin, pregabalin, and this. Only thing is, their side effect profile is worse than the morphine. Right? So you have to tell the patient, okay, you have a cough of say 5 out of 10. What would you prefer? You to have the cough of 5 out of 10, or do you prefer to have the side effects of gabapentin? So let the patient decide. And you can consider pro-motility agent, because not only acid reflux, even the other esophageal refluxes also can cause, even without acid reflux, can cause this neural stimulation and a chronic cough. So you can consider pro-motility agent like metoclopramide, domperidone, and things, again as a trial basis, but not a lot of good evidence there. If you have to give it, if you want to give, say in a patient with say COPD or chronic bronchitis, a good drug would be azithromycin, right? So it will work as in 3 ways. It kills the bacteria, it is an anti-inflammatory drug, as well as it's a pro-motility. But to treat with azithromycin, you have to demonstrate at least this patient is having obstructive component of airway disease. Then, so these are medical management. There is a new concept called, we don't have access again to this, cough control management, that is done by the speech therapists. So that is they're teaching about cough hygiene and methods to control your cough, because this is not a sinister thing, right? So it has been going on for 6 months. It's neurally mediated. You have evaluated them properly. So there's no harm trying to suppress the cough by physical means. Okay, so those are the options that we have at the moment to treat these nagging coughs. But in the future, so all these drugs for the past 40 years, we have not had a proper drug. So we have been trialing with all these different medications. But in the horizon, there are very good drugs. These neuromodulator drugs are appearing, and they will come to us in the coming couple of years, and then of course this lecture will become redundant. Okay, so patient-centered care, this is how we need to manage these people. Work with the patient, tell them, okay, we are giving you trials of medication, this might work, this might not work. You can choose what you want to take. I'll give you all these things. If you find anything that is not working, or if you find anything that is unpleasant, please do discontinue, because it's not working for you, and I know that it's not working for you as well. So tell them like that, and then it's best to have a subjective yet numerical assessment like a visual analog score. So you can say, right, when you came to me, you had a comp of say 8 out of 10, but now isn't it 4? So you're getting better, so it will go away, right? And a term that we can use from ancient times is you tell the patient, okay, you got, after evaluating the patient properly, you can tell them, so you got a 100-day cough. This is coming from the pertussis days, but this term, but you can say, make a dawas siyak tiyena. So the patient will understand. Otherwise, he will go from one doctor to the other here and there, but taking same medication in different brand names. So yeah, so this is going to stay there for 100 days, and this is how it's going to happen. Yeah. So you have to accept. You have to accept, and the patient has to accept, and you have to tell them, yes, you got a disease. I understand it, but we are truly limited with what we have at the moment. This is a disease. If you say there's lead up neck, if you say that, it won't help. Yeah. Okay. So in conclusion, yes, we need to understand that this is a disease, quite distressful. The pathophysiology is neuro-mediated vagal upfront hypersensitivity. Clinical assessment is, if you've done it properly, it's quite sufficient. And if you identify a phenotype, you can treat them and cure them. If not, we will have to wait for the. We can give a trial and then wait for the highly aggressive mutation.